the thing about patient safety is it's hard to find arguments against it, especially when you're pointing out harm that is preventable or harm that we can reduce. The one thing I'm most proud of is that our quality and safety team have a turnover rate of less than 1%, and we have some of the highest employee engagement scores in the system.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Today's guest is Dr. Abraham Jacob, and I invited him on the show because he's spent years thinking deeply and very publicly about what it actually means to be a chief quality officer. Abe's path into this work started the way it does for many of us, as a frontline clinician. He trained in both internal medicine and pediatrics, helped start and build a med-peds primary care practice, and later helped launch a hospitalist program. As his scope grew, so did the questions he was asking. Not just about individual clinical decisions, but about how systems perform, how standards get set, and how teams consistently deliver safe care. That trajectory led him to formal leadership. From 2012 to 2019, he served as Chief Medical Officer of a children's hospital, where he led quality and patient safety efforts and helped implement a high-reliability platform. Since 2019, he's been the Chief Quality Officer at M Health Fairview, a 10-hospital system in Minnesota that includes an academic medical center and an academic children's hospital affiliated with the University of Minnesota. What makes Abe especially interesting for this conversation is that he hasn't just done the CQO role, he's also helped shape how others understand it. He's spoken frequently about the role at the IHI Forum, and since 2022, he's served as faculty for the IHI Chief Quality Officer Professional Development Program, which is actually where I first came to meet him. So he's spent years both living the role and helping other CQOs make sense of it. In this conversation, we focus on the real life of a CQO, what the day-to-day work actually looks like, why patient safety is such a powerful starting point, how accountability and psychological safety coexist in practice, and how the role is evolving beyond quality assurance towards system transformation and value. We also talk about what future CQOs will need to know and be good at as healthcare continues to change. If you want a grounded, experience-based look at what the CQO role means today and where it's helping to steer healthcare in the future, this conversation delivers. Abe, welcome to the show.
Good to be with you, Jason.
Just to start, I wondered if you could give listeners a brief overview of your career path leading from, being a frontline clinician and eventually becoming a chief quality officer.
Yeah, I think after I finished residency, there were 6 of us in my residency program. So I was med peds, internal medicine, and pediatrics, 4-year program. And we were talking to each other, I think it was during our last year of residency, and said, hey, what would you think about starting a primary care practice, a med peds practice? None really had existed in Minneapolis, St. Paul, or in Minnesota. And so really started, the 6 of us started interviewing various health systems in the metro and identified a system that was ready to take us. And, we really kind of created the model that we wanted in terms of having learners with us and admitting both pediatric and internal medicine patients. And so I started in primary care. That was my foundation. I did that for 7 years. Through that, I was medical director of our clinic after about a year or two. And I really credit that because there were 2 of us when we started the practice that wanted to work part-time. So in working part-time, really gave me the space to think kind of big picture about what I was doing, what we were doing, and just loved it. I never had a sense that I was burning out or was sick of it. I just loved just having, again, that free space in my mind to think about what we were doing and how do we do it better. I guess those are my early phases of improvement, if you will. And so I expanded, I knew I could take care of patients individually, patients and families. And then I started thinking about, okay, how do we do this as a collective group practice of 6 people, 6 of us? We started, growing and hiring people. And it was also the early phase of converting to electronic health records. And so now we were having electronic data and registries, and just loved that idea and doing more of that. And we drove some significant improvement work. Um, and then, from primary care was kind of recruited or asked to come back to the university to start a peds hospitalist program. And that was back in 2005, and thought long and hard about that. But I kind of like the idea of kind of building something from scratch, and really did that from 2005 to 2012. And again, through that work, got even more into improvement science, if you will, and variation reduction, essentially. Did some more training out at Intermountain Health, through their advanced training program. And then decided I needed to kind of speak the love language of finance, and did the Masters of Healthcare Administration here through our School of Public Health. And then shortly after that, stepped into the chief medical officer role, which was newly created at our children's hospital. And then again, that was for 7 years. And now I'm into my 6th year of being chief quality officer across our health system.
What a journey. And thanks for that recap. So then tell me a little more about what sparked your interest in quality and safety specifically, because it sounds like this was a bit of a gradual process, but were there particular mentors or particular projects that kind of led you in this path?
Yeah, I think I was just naturally interested in thinking about improving kind of, it's all based in improving outcomes for our patients, not just the patients I'm taking care of in front of me, but how do we do this collectively, have a much larger impact across the region or the community we were serving, then, at the hospital, across all the patients we admitted. How could we, make sure that for the really hard work we were putting in every day to take care of patients, that at the end of the day, we could show yeah, we do a pretty good job in terms of outcomes like that. I think that's always been kind of an internal motivation, I think, for any of us that go into medicine. And, we don't do it to just kind of punch the time card and do our shift, we want to feel like we're doing right by our patients. And for me, it was about how do we collectively, because I knew that I was really dependent on the medical assistant, the nurse, the pharmacist, the respiratory therapist, the entire team of people, the registrar, to kind of get information right so that we could, as a team, take care of the best care of this patient. And so I love that idea of working as a team to deliver good outcomes. And that has always, I think, been a part of what has driven me and why I've kind of always migrated towards doing improvement. Now, I've been really blessed to have really good mentors around me, people who kind of, I guess, recognize that, passion I had for improvement and time I would put into it. And they'd tap me on the shoulder to do some, whether it was a leadership development thing or, you should go to this conference. In fact, one of my early mentors recommended I go to early IHI conferences in the early 2000s. And I remember seeing Don Berwick get up there and do a keynote. I think this was the Office of Clinical Redesign. It was when they used to have an ambulatory improvement conference every spring. And just came back with my pants on fire, yes, this is what we have to do. And so, I don't know, I just felt really energized. I've always felt energized by the idea of improving outcomes.
So you find yourself now in the title of a chief, for the role of chief quality officer. And I think that what that is might not be as obvious to the average listener as a chief operating officer or chief medical officer. That these are titles that we're much more accustomed to hearing. We can kind of wrap our brains more easily around what the job entails. But I wanted to dive a little bit into what it is to be a chief quality officer. And I wonder if you can kind of share what your job, what your experience of being a CQO is on a day-to-day basis.
Yeah, so I guess I think of it in terms of, a couple different frameworks. One is there's just a base level of quality assurance, right? And that's usually in a regulatory frame. These are the minimal things you have to do to kind of demonstrate that, you should stay in business. And so that is just quality control or quality assurance, right? If you don't get that right, it's really hard to do improvement. You just have to, make sure you're doing that and doing that really well. Then there's okay, you've satisfied whatever regulators or organizations around you that you can, stay in business and just in terms of you provide basic quality care. Then the real interesting work, I think, comes in improvement. Like, how do you get better? Like, how can we deliver better and better outcomes? And for me, in many ways, sits in the foundation of patient safety. Like, I think of this in terms of there's like a million things you could improve, right? Like we get asked every day for help to improve all kinds of stuff. And for me, you need a place to start. And for me, it's always been about just reducing harm. Let's just start with reducing harm and focus on reducing harm. And I bet find a lot of improvement in those spaces. And sure enough, we have. And so we've, when I started, both when I was chief medical officer and now as chief quality officer for the system, that's always just been the foundation. Like those are just table stakes. We are going to get up every day and we're going to figure out how to reduce harm. And that's, and really focused on preventable harm. And then, beyond that, there's just, I think the work of clinical variation reduction. So there's lots of things we do where you find there's just, wow, there's 10 or 100 different ways we do this same clinical process. Can we imagine creating some guidelines, some recommendations around standardizing the approach to delivering a baby, to managing an ear infection, to managing pneumonia, to, having an ECMO patient, right? Or solid organ transplant, or it just goes on and on and on. And so we have a core area in just reducing, variation. And then I think the next or another level is how do we can kind of continue to educate and train all the operations people we support in the science of improvement and patient safety, right? High reliability. And so this is about teaching people how to fish. So they're not always calling someone from my team about doing a local improvement effort on their local unit, OR, or clinic. Like we want them to be able to do this, have agency and ownership and, good education and training about how to do this. So we've done, I think every good quality shop should have some efforts around educating and training, not only the people around them, but even your own people. So we've created, pathways, even in our quality and safety team, about how do you become better at leveraging the electronic health record to pull data out yourself instead of always calling our data analytics team, right? How do we make sure that our team is advancing in terms of, green belt, yellow belt, black belt training? Like we encourage that, and that's a part of their kind of improvement as a professional. We're also have done some work in education and training around looking at disparities. How do we get different, do subgroup analysis based on, race, ethnicity, insured, not insured, male, female, language, all of it, right? So we can understand where the biggest opportunities to close gaps in care are. So I don't know if that might have been a little rambling, but again, I think it starts, quality assurance or quality control, patient safety, and just harm reduction, doing good clinical variation reduction, having a system around that. And then, how do you educate and train everyone around you, including your team? If you have kind of those fundamentals, then you can pretty much tackle anything, right? Like you can, then it's just a matter of identifying what your priorities are as a system and getting after it with kind of the foundation you've built.
Yeah. I mean, digging into that a little bit, you mentioned, and I've heard this before, kind of focus on patient safety is both an easy sell and a great place to find ways to improve. It sounds like, by the way you said it, you have some good war stories of successes in patient safety.
Well, the thing about patient safety is I have found, and you probably found this too, is it's hard to find arguments against it, right? Like especially when you're pointing out harm that is preventable or harm that we can reduce. That I find that easier to get people engaged in the work to kind of do better. And there's a myriad of patient stories you can tell that are heartbreaking and really provide a compelling reason to change. And so again, I think all of us are calling to medicine, whether you're a nurse, pharmacist, RT, clinician, is that you're going to do no harm. And I think focusing on patient safety, particularly reducing preventable harm, is easy to sell. So for me, it's a lazy way out in that I don't want to deal with all the change management, everything else. Like safety is an easy sell. Like that, it doesn't. It's for me, it's easy to walk into a room of respected leaders and say, yeah, we harmed this patient. What are we going to do about it? That's an easy story to tell and to gather some momentum around.
Are there initiatives you remember from patient safety that you found that you had some real success with that you're proud of?
Ooh, so when I say I'm proud, I'm not proud of myself as much as I am of our team and the system in responding in the way they have. So over the things, I guess that we've had kind of 6-year lows in central line associated bloodstream infections and catheter associated urinary tract infections and C. diff, the basic stuff. We've had a 40% reduction in surgical site infections. Our observed to expected mortality has gone from consistently above 1 to now consistently between 0.6 and 0.7. Our ambulatory care composite, I think by the end of this year, we'll have 10 or 12 measures that are of our 20 that we track that are, above the 75th percentile. So this takes a ton of hard work and alignment and focusing on the foundation of all the things, I just talked about. And, we've had a reduction in preventable harm. So we track serious safety events in our system. And the way we measure that, we've had, the last couple of years, year-over-year reductions, which is great. And so all of that success really builds a lot of kind of momentum and morale around, what's next, right? Like the next thing that's going to be harder to sell. Now, I've certainly had my share of failures as well, and learned from that. I would say, Jason, the thing that I wish I would have known, when I started this job would have been I guess I did not anticipate the impact that turnover would have on our performance as a system. So we did such hard work to establish these standards of care, these care pathways. We go through the pandemic and, as we all know, we had an exodus of quite seasoned nurses, respiratory therapists, pharmacists, where we lost a lot of that institutional knowledge because they retired or decided to do other jobs. We had an influx of brand new, nurses, respiratory therapists, pharmacists, clinicians who frankly just didn't know the standards. And what we saw was that, because of the urgency to onboard and get them, in our ORs and our ICUs and clinics, I think we lost some of that, the stability of the system because people just didn't know the standards. And so I think going forward, I have a much deeper respect for the need to appropriately onboard, educate and train and retrain to kind of what your standards are. If you don't manage that thoughtfully, you will have a decline in your performance. And so, we experienced that. Now I think we're back on track and it's more stable. But again, the question I always ask our teams, like, what did we learn from that? Like, how are we going to make sure we prevent this from happening again? And so that's been, I think, significant learning. But, in terms of your original question, like, what am I, the one thing I'm most proud of is that our quality and safety team, which has probably around 160 to 170 people in my part of the system, have a turnover rate of less than 1%. And we have some of the highest employee engagement scores in the system. Of all the metrics I look at that I'm most proud of as a leader, that's it. Because I know that means that our teams feel like they're being developed and nourished, in terms of their professional development. If they leave, I encourage them to leave. If it's going to a higher role or higher leadership position, that's what we are here for. We want to build leaders. And I want to make sure that our team feels connected to each other and they feel like they can come to work and feel like they're getting meaning at the end of the day. They could be doing a million other things. And I feel like it's our job as leaders is to make sure they're feeling fulfilled in terms of finding meaningful work, that we're answering kind of their call to medicine and finding kind of a deeper sense of purpose. And, quality and safety is kind of an easier sell than many other things, that we can do in the world. So, but to answer your question, original question, that's probably the metric I'm most proud of, is just the impact this has had on our teams.
Yeah, that's great. You've spoken a lot at leadership forums, like at the IHI forum. From your perspective, I'm curious what distinguishes kind of effective leadership, or what defines good quality leadership from your point of view.
Assuming leaders have a base level of competency in terms of understanding strategy and driving strategy, I think, really good, effective leadership, also the ones that I've, I've been fortunate enough to have mentors around me that I've really learned a lot from, and feel like, wow, he or she is a great leader. And the things that kind of pop out in my mind are, one, their authenticity, like there are just not pretenses about them. They are, honest and truthful, and they will speak truth to power when it's difficult, especially when it's difficult. One, I think two, I think they also have a certain amount of emotional intelligence, like they just know how to read the room and how to kind of connect with their leaders and their people, and also know when they need to kind of slow down in terms of the pace of change. Those two things, I think, are really hard to not replace. In other words, if you're not authentic and you don't have some degree of emotional intelligence, I think you can only get so far. I mean, I think you can be a good leader. I just don't know how sustainable it is. And I just would hope that any one of member of my team could feel like they could text me and reach out to me, and that we've established significant levels of psychological safety across, not only my team, but the teams we support. So if I had to say three things: authenticity, emotional intelligence, building psychological safety. Like, you can't show me a really good leader that doesn't demonstrate kind of those three domains pretty well.
I'd like to dive into one of those that you mentioned, because I think there's a natural tension for quality leaders who are expected to drive accountability while fostering psychological safety. And I'm curious how you navigate that tension.
Yeah, I think you asked, I think, the most important question. So being fair and holding our teams accountable, yet creating high levels of psychological safety. And so there's different ways to measure psychological safety, and there's been a lot of writing about this over the last decade or so. But there's a important article that came out, I think 2017, in the New York Times Magazine about the Google study, where they looked at the factors that drove their most high performing teams, and lo and behold, levels of psychological safety was the most important thing. And so they looked at that, they dove into that, like, how could we scale this, across all our leaders? And it's really hard to do, because you have to be able to nurture some sense, like in a room or in a group, that people feel safe to speak up when they disagree or have questions about the direction, the team is going in. And it's okay to have those conversations, and not, for me as a leader, not to get defensive about it, to be always in the state of inquiring more about, like, tell me more about how you feel that way. I want to understand more. And, once that individual has made their, argument or their explanation, we can just say, you know what, I heard you. I feel like in my gut, like, or based on other data, I still think this is the way we need to go. Are you okay with that? And if yes, I disagree, or think, at least we as leaders, we have, understood all sides, of the issue. And so I remember early on, and when I was medical director of that primary care clinic I told you about, I had one of my partners who it was like what I would call chewing gristle, like just complaining about everything, right? And it can be really frustrating as a leader or trying to drive direction when you have someone who's constantly like, well, blah, blah, blah. But as one mentor told me, like, you need to use those individuals as little birdies in your ear about, what you're not, thinking about. And so that reframing for me was really, really helpful in terms of saying, okay, instead of that person being a bother or a pain in my butt, I'm going to really seek that person out to make sure I understand what I might be, I'm not missing something here, about this plan. And so now, having said that, those people can still be a pain in the butt, but I do appreciate when people feel like, and the other thing I think as a leader, is to kind of acknowledge when someone does speak up, and it's a simple thing to do, right? And if you're a clinician and you get called to a rapid response team, that ends up being kind of not much, right? The patient's okay. You gave some fluids, the patient responded, didn't have to transfer to the ICU. I think making a point as a clinical team to say thank you to the nurse or to whoever called that rapid response team, like, thank you for your concern. We'd much rather know about this than not. I think it's devastating for that team to come and say, why did you call this RT? This patient's fine, right? Like that, there's nothing that suppresses people speaking up than our response to things like that. And even as a leader in a meeting, I was, we had a large, gathering, our kind of our yearly gathering of our entire quality and safety team. There were probably about 80 people in the room, and there were 70 some online, watching virtually because they're remote. And at the beginning, as I was speaking, and I was speaking really eloquently, I got to tell you, like I was just, knocking it out of the park. Someone, had the courage to kind of say, hey, Abe, just so you know, we can't hear you. Like when you walk away from the computer, because I was walking around the room, and I said, if you wouldn't mind, could you tell me who said that? And it was a woman who I know on our team. And I said, now she just demonstrated psychological safety, and I want to thank her for role modeling that for all of us. So, she's in this virtual room of 70 people, a physical room of 80. It'd be really easy to just not say anything and go through an hour of me kind of going in and out and not getting much out of that. But instead, she had the courage, I call it courage, to speak up and say, hey, Abe, just so you know, we can't hear you. I mean, and so we adjusted, and then people could finally hear me. And so I think it's important for us, for leaders, to affirm and acknowledge when you see it happening, because it happens quite a bit. I don't think we probably acknowledge it as much as we should as leaders.
Yeah, well said. And the article you alluded to earlier was what Google learned from its quest to build the perfect team. And I'll put that in the show notes, for, as you said, from the New York Times Magazine, written by Charles Duhigg. So I'm just putting that as a note here, so I'll include it in our show notes. And, I can imagine that, before you had a leadership title, you had experiences of leading maybe with informal authority. And you might see this on your teams now, people who have a lesser title, but who are showing themselves to be leaders standing out amongst the group. What have you learned about kind of that informal leadership?
I think those are probably the most important roles of leadership in any system. People who have informal roles or seen as leaders on their team because of their high degree of, skill sets, just the way they, handle people. Like there's any number of people that are just flying through my mind right now of people who don't have formal leadership roles, but man, I look to them and reach out to them all the time just to get their insight or input, because I know they're respected. They're very thoughtful about, the work they do. So I try to hold those people up as much as I can, just to kind of continue to affirm and encourage them, because I think they have, it's just a matter of time before they, if they want it, they'll be asked to be in a formal leadership role. And so, again, you see it in on any unit or microsystem. You can go ask, anyone who works in there, like, who are your informal leaders, or who do you really respect around here? And you can quickly find out who they are. So I just think it's really important that we're thoughtful and, again, intentional about acknowledging those people, holding them up, and thinking about how we mentor them into more, formal leadership roles. I mean, that is the heart of quality improvement, is you have someone who's willing to take the initiative to help drive change, even though they're not given a formal leadership role to do that. They just they are internally motivated to get to a better, a better system or better outcomes. And they often lead that just by voice or by modeling it.
How has the role of chief quality officer changed since you stepped into it in 2019?
I think my perspective on this is that initially a lot of CQO roles were probably thought of as more as a quality control or quality assurance thing. Like, just can you help us stay in business or avoid, financial penalties or getting into big trouble with our regulators? But I think the more mature organizations really rely on their chief quality, their quality operations to drive significant improvement and to help think about how you transform the organization in that improvement, right? So it goes way beyond just quality assurance or control, but how do you drive significant, system transformation to get to, different levels of care delivery and outcomes than what you experienced before. So that those levels of transformation are really, I think, about how you really leverage the experience of patients and families in terms of touch points with our system. I think it's thinking about the financial implications of what we do. How do we drive significant value, whether that's through value-based care arrangements, shifting models of global payments of care, like we're seeing with CMS here in the US. Again, getting to this idea that we are significant stewards of the healthcare dollar, and we should be able to drive better value than we currently do based on the outcomes we get. And so I think that's how the chief quality officer role is shifting, continues to shift. And there's kind of the chief quality officer, I think many executive leaders have to think about just the dynamics of what's happening in their environment. So here in Minnesota, we have a different pace of an aging population than other parts of the country. And so how do you really get the system prepared and organized to make sure you're able to manage what is a different, variable than you might have, say, in the Southern United States or other parts of the country. So I think there's a lot of different things. I think the chief quality officer really has to kind of have their eyes and ears out to just understand how you kind of prepare the system for various levels of transformation.
Yeah, and as the CQO, I think there's a lot of different hats and a lot of different types of work that you're being thrust into kind of all the time. If you were designing a CQO role from scratch today, what would you intentionally do differently?
Ooh, that's a good question. So I oversee patient safety and employee safety. I think the two are linked, and I do think a chief quality officer should oversee both. That's not true in many organizations. I just think, you can't have safe patient care if you don't have safe staff, staff that feel safe. I also think regulatory is an important piece. And so I think overseeing regulatory to make sure you've got the quality assurance or control piece down. I also think having, capacity and being resourced to drive education and training around improvement science and high reliability science is also really important. I think there's also a key role that chief quality officer should be playing in the value-based care population health side of things, right? So that's just in terms of driving the value side of the equation. So those would be I think the most significant areas that I think a current CQO should really be thinking about. And, in many organizations, the oversight of those may fall under different parts of the organization. For example, patient experience in our system has a separate leader, but I'm talking to them all the time because I just think part of what we do in quality is really critical to patient experience. And that if we don't think about patient experience, then we're not delivering good quality. So I think there's a lot of it, codependency with various functions in the organization. And so it's just, I think for a chief quality officer, just knowing, when to kind of reach out to those colleagues or partners, stakeholders, and driving, high quality work.
And you've been an instrumental part of and one of the core faculty for the IHI's CQO professional development program for a while now. How many years have you been doing that?
Let's see. I think I stepped into that in 22, if I'm not mistaken. Maybe it was 21. It was 21 or 22. But yeah, it's one of the joys of my career is to be a part of that program, mostly because I get to meet people like you, Jason, and other kind of thought leaders in quality and safety. And we get to think about inviting really remarkable leaders in quality and safety to kind of speak to the group. And again, just hear kind of how people are thinking about the work, I think has been really valuable. So I've really enjoyed that. I think it's, as you know, it's been really important for leaders in quality to be connected to each other, to have kind of a family, if you will, of quality and safety leaders kind of around the country. Not only to see them at various meetings, but also just to think through like how are you thinking about the exact same problem I'm dealing with, in my part of the country. And so that I think has been again, I'm really grateful to have had that opportunity and experience with IHI.
And what's most surprised you about your experience with that those three or four cohorts that you've been through?
I'm always amazed that everyone wants to learn more about what your org structure is, even though we always say like, no org structure is the same and it, depends on your system. But it's a pretty predictably reliable question. Like, hey, can people share, Visios of their various org structures? I'm also been surprised at how stable the key driver diagram has been. And, that forms kind of the basis of the development. Every year we looked at, changing it or trying to change it. And we're look at it and like, yeah, I don't know if there's much I would change. Like it still ends up being about right, and I give David Williams, who was one of the original faculty of the CQO development program and helped develop the key driver diagram, a lot of credit for this. I mean, I think they put a lot of thought into that, and it is, I think, held up pretty well. Now, there may be different points of emphasis in that key driver for various people, depending on where you are, as a leader or as a system. But generally, those are still, I think, the right things to pay attention to. So, and I guess the other thing I guess I've been pleasantly surprised at is just how great, the year over year group, the cohort has been, like just as individuals, as leaders. It's just been so fun to get to know them over the last couple of years.
That's great. I'm glad I asked that question. I did not expect org structures to be the leading answer there.
Yeah, who doesn't want to see someone else's org structure, right? And I think it's a demonstration of maybe the psychological safety we've built in as a group of CQOs or quality leaders, I should say, is that people feel comfortable enough to ask for that kind of information, right? And I've been willing to share it. It's like, well, I don't know if you'll make much out of this, but take with it and do with it what you want.
Yeah, no, it really is a testament to that, and creating these psychologically safe spaces where you can ask the question that might seem silly
my guess is, the reason we find people asking about it a lot is because there aren't great benchmarks about how to resource quality and safety, right? I mean, there's some reasonable benchmarks for employee occupational health, depending on the size of your organization, for infection control, but not so much for quality and safety, because everyone's definition of who's on your quality and safety team is just a little bit different, right? For some people, they have practice education nurses, other people have CDI, other people have, patient experience, other people have, system science, system engineers. It's just a little bit all over the map. And so I think that's probably the basis by which people want to look at org charts, is they're trying to understand what's the appropriate level of resourcing to do, this really important work. And I don't have a great answer for that.
What advice would you give to people listening who aspire to do a CQO type role?
So what I would say is this is one of my mentors told me this early on. This was maybe 20 years ago now. He said, just do improvement work, just go improve stuff in the spaces you're leading, or could be. And so I've always remembered that, and it's to this day, I just think, okay, what can we make better today? Like, what do we need? Because as especially as clinicians, you see all kinds of defects in the system. There's a lot of variation going on, and so just standardizing any number of workflows or clinical processes is an improvement, and you will get to a better place. And so there's so much experience and so much learning from just doing kind of improvement, and having, understanding what change management takes, learning about other people or how other people work, understanding workflows better, what are the human factors involved in this particular process. I think for people who are really looking to do more quality, I would encourage them to just go in your whatever sphere of influence you're in right now. Go do improvement work. You'll learn immensely from that, more than going in to get another degree. I would just have that lived experience of doing improvement. It'll give you so much credibility and knowledge in terms of what comes next.
Yeah, well said. You've spoken about this before, and we've all kind of lived through the challenges of COVID, the burnout epidemic that we continue to live through.
Yeah.
What gives you hope about the future of quality and safety in healthcare?
The thing that gives me hope is that, as quality leaders, I think we serve as kind of the true north or the compass for all the organizations we work in. And it's our job to kind of point to, the direction of where the system should be going and be anchored in terms of delivering really good outcomes. I also think it's really important that we create, again, those levels of psychological safety for, again, our teams, and not just your quality and safety team, but the teams you support. How do you build connection? How do you think about keeping your staff safe, both physically and psychologically? I just think this is deeply important because then that allows to do all kinds of remarkable things in terms of helping, all the hundreds and thousands and millions of people that have chosen healthcare as their profession to give them kind of a deeper sense of purpose, that allows them to kind of grow and to kind of hopefully get to some sense of an answer to why they chose, this career. And so there aren't many jobs that, you can wake up to and feel like you're in true service, to someone else and get paid reasonably well to do that. It's and I know there's a lot of people that complain that we don't get paid enough, but when you look at what we do and all the sacrifices we make, it's really in service to patients and families and to each other, right? To do that better. And so I think it's really inherent on us to help people do that. And that's the thing that gives me hope. It's like, okay, that's a pretty cool thing. It's a privilege to get to help people and get healthier and get them back to function.
And that's a great place, I think, to round out our conversation today, which I really appreciate you coming and joining me today. For listeners who want to connect with you or follow your work, what's the best place for them to do that?
Yeah, my email's in the public domain, akj@umn.edu. Feel free to send me a note, and would be happy to connect with them, and thinking through with them where they're at on their journey. And I again have benefited and been blessed by so many people who've done that for me. And part of my commitment is to kind of carry that forward and continue to do that for other people, and really, really enjoy doing that.
Very good. And can we link to your LinkedIn profile as well?
Yeah. I forget about LinkedIn. I'm not obviously don't dive into that a ton, but I will check into it often. So if you want to message me on LinkedIn, that'd be great.
Fair enough. Well, Dr. Abraham Jacob, Abe, thank you so much. I appreciate your time. It was really great to hear about your journey as a frontline med-peds clinician up to CQO, and all of the great things that entails for now and into the future. So thanks so much.
Yeah, thanks for having me, Jason. And thanks for what you do in terms of telling these stories. I think it's great, and in many ways, you're providing a great service for all of us. So thanks for what you do.
Yeah, thank you so much.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.